My name is Mohammed Allo. I'm a cardiologist. Some of you guys know me. Some of you guys recently rotated with me. So welcome back. Today we're going to talk about lipids and some crazy advanced lipid stuff that I'm sure you've probably never heard of. So just before we start, if you were recently on cardiology, don't answer the questions because you probably know the answers. Where does cholesterol come from? Huh? Inside and out. So inside, where does it come from? Which one is more, first of all? Do you create your own cholesterol more than you consume or more than you eat, or is it a little bit of both?
In general, people eat.
No, not really. So no, people don't usually eat that much cholesterol. What kind of foods have cholesterol in it? Huh? Say it a little louder.
An animal source.
Like which animals? Be specific, because it's not that common. Like if I told you, go get me a bowl of 300 milligrams of cholesterol, what are you going to get?
Meat.
Meat? Which meat?
Like beef.
Fat? Like beef? No, not really.
Pork.
No, not pork.
Shrimp.
Shrimp. So in the US, there's not that many foods that contain a lot of cholesterol. Shrimp would be one of them. What else? Eggs. Certain parts of the eggs, definitely. One other one, but like I said, in the US, we don't eat a lot of cholesterol. Octopus, things like that, really weird foods that we don't eat a lot of in the United States. So that's a small portion of our diet. Unless you eat like 20 eggs a day or all you eat is shrimp, that's a different story. But the rest of the cholesterol comes from where? Your body makes it. Do you know where? Liver. Just your liver? Skin? Somebody said skin? Does skin make cholesterol? Fat stores? No. So here's the thing. Every cell in your body makes cholesterol. Do you guys remember molecular biology? Let's pretend this is a cell, right? Not a lipid. Let's pretend this is a cell. This is cholesterol in the cell membrane. These are phospholipids. Most cells are a bilayer, double phospholipid bilayer. This one is not. This is a lipoprotein, but I'm just using it as an example. Imagine it's like a brain cell or a muscle cell or a skin cell or intestinal cell, whatever. There's free cholesterol in the membrane, whereas these are cholesterol esters inside. This is a lipid, a lipoprotein. Cholesterol esters are on the inside, but in the membrane, it's free cholesterol. It what keeps the membrane of each cell like fluid, so that it can move around and bend and turn, and it compresses. But every cell in your body makes cholesterol. People think it's only your liver. You hear online, they're like, oh, your liver makes 90% of your cholesterol. That's not true. Your liver makes just as much cholesterol as any other cell makes. Most of the cholesterol in your body is made in every single cell. That includes like your eyeballs, your skin, your intestines, whatever. Any cell anywhere in your body makes cholesterol because it needs it. But the extra cholesterol is the problem. Every cell makes too much cholesterol for most people. There is a genetic disorder called hypobeta-lipoproteinemia. You don't have to remember this. This is beyond. You guys are all internal medicine, right? Anybody trying to go into cardiology? One maybe?
Yeah.
No, did you change your mind yet? Or no?
Just making sure you already knew that.
No, okay. If you already know it, then don't say anything. So I forgot where I was. But anyways, so people think that that liver makes all the cholesterol. No, but all the extra cholesterol gets transported back to the liver to then be eliminated. So maybe that might be the confusion. All of the cells make cholesterol. They get packaged into these lipoproteins, and we'll get into the details. But the lipoproteins get trafficked back to your liver, so your liver can get rid of it. And we'll get into the details. But your liver's job is mainly to get rid of cholesterol. Sure, it makes some too, and it can send it out into circulation and all of that, which we'll get into. But it's all made in all the cells in your body, transported back to the liver to be eliminated. Then it ends up in your intestines, right? And then the problem is your intestines reabsorb a lot of it back. So that's where the food one that you're talking, you eat cholesterol, let's say you eat a lot of shrimp, right? You eat a ton of shrimp and you love shrimp. It does end up in your intestines and it can be absorbed more. They have found a linear relationship between the amount of cholesterol you eat and how much your cholesterol goes up. It depends. It only really works at extremes of cholesterol intake. Like if you just eat a couple shrimp here and there, an egg a day, probably not as consequential. But if you're eating like 10 eggs a day, 100 grams or 200 grams of shrimp a day, then it's a linear line straight to more cardiovascular mortality and all-cause mortality for obvious reasons. You will at that point break the point where that is too much cholesterol and you will absorb most of it. So this lecture is more for like cardiologists and cardiology fellows, but some of you guys want to be cardiologists. But no, like here's the thing. We only see the crazy stuff. Like cardiologists, you send me the crazy lipids, the crazy heart disease, all that stuff. But most of cholesterol is treated by you guys. You guys are the front lines of lipid management and lipid treatment. So 90% of cholesterol probably in the world is treated by you guys, and you only send me the crazy stuff where I see them in the hospital, and I get to see the ones with the LDLs of 170 that are untreated. Do you guys know your LDL? Anybody here not know their LDL? Raise your hand if you don't know your LDL. Okay, everyone else seems to know it. Anybody over 100? Whose LDL is over 100? Don't be shy. Raise your hands. Anybody? Okay, everybody's laughing. So I'm assuming everybody's LDL is over 100. Okay, let me ask you another question. Why? It's almost 2026, right? In about a month or two, it's going to be 2026. Is there a reason to have an LDL over 100? Like, what's the advantage? Is there anyone that's like, I want my LDL to be 150? No, you guys seen enough cardiac patients, right? There's no reason for your LDL to be that high. What's the easiest way to lower LDL? Wait, let me ask you this. Can vegetarians have high cholesterol?
Yes.
Are any of you guys strictly vegetarian? Some people maybe. Okay. Do you have high cholesterol? And you don't have to answer specifically. Can you? Could you have high cholesterol? How can you raise your cholesterol by being vegetarian? Well, first of all, yes, a lot of it is genetic. You could just be born. Like if you have familial hypercholesterolemia, it's genetic. There's not a whole lot of plants you can eat to lower it. But what about a normal person? They're kind of they're vegetarian. Is there anything you can eat or not eat to raise or lower your cholesterol? How can you lower your cholesterol? Well, how can you lower your cholesterol without medications? Why don't we start there? Just spit it out, huh? Exercise. Who said exercise? Who thinks exercise lowers cholesterol? Raise your hand. Oh, nobody raised their hand. One person, two people maybe. So exercise has almost zero effect on cholesterol, right? We still tell people diet and exercise because exercise helps your cardiovascular system in other ways. It reduces insulin resistance, hypertension, obesity, like adipose tissue goes down, which is very inflammatory, all that stuff. But exercise in and of itself, to lower cholesterol, you have to be running like 30 miles a week, which I don't think anybody could do. It's just not reasonable. How can you lower your cholesterol without medications? What else can you try? So exercise, probably not. Diet, like how? So two things that you can do in diet, right? You can add more fiber, like she said. What's fiber? Like what? Greens, cellulose, beans, nuts, vegetables, fruit, all the good stuff, right? What else can you do? What is it? Decrease fat. All fat? Like canola oil, olive oil, avocado oil? What? Okay, saturated fat. So what is a saturated fat? Tarek knows he memorized the lecture. Besides you, what is a saturated fat?
Hydrogenated.
Fully hydrogenated, right? Or partially?
Fully.
No. Okay, but let's break it down simple. Forget the fake, butters, spreads that we make. Just real food. What is a saturated fat? Anything that is solid at room temperature. Exactly, right? Like what? Give me an example. Butter, ghee, cheese, coconut oil, bacon, lard, fat on steak. What else? You guys are smiling like, oh man, it's all the good stuff. No, I don't think you guys eat a lot of that stuff, right? I mean, I don't personally, but anybody in medicine probably doesn't. But are you like a person that eats like double cheeseburgers every day and fries your fries in beef tallow or lard? Thankfully, we don't do that much in the U.S. The hospital cafeteria? The hospital cafeteria is pushing you that way? Well, try to stick to the vegetarian stuff maybe. Or bring, like, they always have chicken or salmon. Usually they have a fish and a chicken and turkey a lot. They have cold cuts usually. But any lean meat generally is fine. Even like some red meats, they're lean cuts like filet. They're obviously the expensive ones. But fish, salmon. Do you guys know what a Mediterranean diet is? It doesn't necessarily have to come from the Mediterranean region. Like Japanese people, people in certain parts of the world, they eat a more like wholesome, nutritious diet. Lots of fruits and vegetables, lean meats, fish, beans, nuts, all that kind of stuff. Like natural food that you would just find like in the ground, for example, walking around the planet, or swimming in the ocean. But like the stuff in the supermarkets, that's like Pop-Tarts and Doritos and like, packaged, processed foods. It used to be that trans fats were allowed in the US, but they've, for the most part, been banned. Those kind of foods inherently aren't evil, but a lot of times they're just high in calories. So it's very hard to control your weight because they're very high in calories. I'm not saying you should like gorge on those foods or that you should avoid them completely. Like you said, the hospital sometimes doesn't give you too many options, so you gotta just be kind of careful with that. So what else can you do to lower your cholesterol without medications? We said saturated fat, reducing, and increased fiber. What else can you do? Omega-3? I mean, not really. Omega-3, it's very controversial, the fish oil stuff. I don't know that it shows incredible benefit. It does cause AFib more than we'd like, but it doesn't seem to have intrinsic properties that, for example, lower cholesterol. They've tested that. There was a trial that tested like CoQ10 and cinnamon and fish oil and all that stuff, garlic even, red yeast rice. Didn't really seem to, it didn't beat placebo, and it certainly didn't beat Crestor, even 5 milligrams of Crestor, rosuvastatin. So what else can you do without medications to lower your cholesterol? That's it. That's why everybody's quiet. There's nothing else. You can reduce saturated fat. You can increase fiber. Fiber reduces your cholesterol 1 to 7%, depending on the studies. It's not huge. It competes for reabsorption in your intestines. Plant sterols. Cholesterol is a sterol. So plant sterols will compete with reabsorption in your intestines. It almost functions like Zetia almost. It competes or kicks out cholesterol so you don't absorb it. Sometimes the fiber, it has a lot of cellulose, like she said, may kind of like bind fats or other foods, so you kind of excrete them or poop them out without them being absorbed as much. And then the saturated fat, that can have a huge impact. So if you're eating a not terribly unhealthy diet, but a fairly decent diet, how much can reducing saturated fat change your cholesterol by? Let's say your LDL's 100 just to keep it even. What would it drop to? Can you drop it 5% or 500 or 95%?
5%.
5?
2.5.
2.5? 10? It kind of depends. But yeah, usually around 10 to 18%, depending on the study. Depends on your diet. Some people are hyper responders to saturated fat. Like if you start eating a stick of butter a day or something like that, your LDL is going to go up to like 200-300. Other than like the rare individuals that have that problem, most people, if their LDL is like 110, 120, if they start eating more saturated fat than usual, they'll probably go to 150, 160. Most people, and that's what we see in the data. So for most people, if they cut their saturated fat, let's say you don't really like go out of your way to eat red meat and lots of saturated fat and butter and bacon, if you eat kind of a healthy diet, you can reduce your LDL usually about 10 to 15%, somewhere in that range. But with medications, what's the lowest cholesterol? What's the lowest LDL you guys have ever seen in the hospital or in your clinics?
40.
5?
40.
Oh, 40, okay. What else?
28 I saw.
28? Anybody seen anything lower than 28 or higher? What's the lowest?
That would be in your clinic.
My clinic? Yes, I have a lot of 5s. I don't know who said 5, but there's definitely some 5s. What's the lowest LDL cholesterol you've ever seen? Mine was a negative 17. Is that even real? It's a calculation, so it's not real. Your total cholesterol, you take your total cholesterol, throw out the HDL, you're left with triglycerides, really. You divide that by 5 and throw that out, and that's your calculated LDL. It's not super accurate. When LDL is super low, like if you're on Crestor 40 and Zetia and Repatha and all this stuff, like the people who had triple bypass and then stents and then a stroke and then more bypass, for people who need to be super low, the equation doesn't really work that well when your LDL is that low. Like if your LDL is really like 10, and we do the calculation with a normal cholesterol or whatever. If we do the Friedewald equation, you're gonna end up like a -10, -5, 3, 1, 2. It's not real. No one's LDL is actually that low. That's why we measure something called ApoB. So just so you guys know, let's say this is a low density lipoprotein, all right? You guys you might hear me talk about on social media LDL versus ApoB versus lipoprotein A, whatever. So let's say this is a low density lipoprotein. This is the cholesterol. The yellow balls inside is the cholesterol. These are the triglycerides, the purple ones. They're a glycerol. There's 3 fatty acids connected to like a glycerol backbone. This structural molecule is something called an apolipoprotein B. It kind of holds the lipoprotein together. The reason we can measure this on LDL is because each LDL particle has 1. So in a sense, so the cholesterol inside the LDL is not the actual problem. It's the total number of particles that is the problem. So you could run an NMR, like the nuclear magnetic resonance on the lipid panel, which is super expensive and probably is never going to get paid for. It gives you 40 results. Only one of them is useful. It's LDLP, LDL particle count. Usually it's like 1,200 to 3,000. To get super low, we want it like under 400 or 500 to get into that 5th percentile, like the lowest of the lowest of the low. But if you just check your ApoB, which is like a $5 test, you get a particle count in a way. It's a concentration of total particles. It's the total amount of these that is causing the problem. Imagine you're on a highway and there's a traffic jam, all right? What's more important, like for the traffic jam to clear? Is it the total number of cars plugging up the traffic or the people inside them, the people inside the cars? Does it matter if one car has four people in it and a truck or a van has 15 people in it or another car has only 1 person in it? What matters more, the number of people in the cars or the total number of cars? The total number of cars is what's giving you the traffic jam. So the same thing happens with lipoproteins. The total number of lipoproteins crashing your arterial wall, in your carotids, in your brain, in your heart, that is what's giving you atherosclerosis. It's a concentration gradient of too many lipoproteins, and they're all trying to go back to the liver to be eliminated, but they're crashing your arteries like in your legs and kidneys and heart and arms and wherever else, and that is the problem. And when they crash, they aggregate, they get destroyed by macrophages, the cholesterol ester all dumps into the arteries, they aggregate, they create foam cells, reactive oxygen species attack it, and eventually like it crystallizes and calcifies like decades later, obviously, but it's a process that's almost irreversible. Although now we are finding that with super insanely low LDLs, we are starting to see regression ever since Repatha came out. When you add Repatha to a statin, to a Zetia, and you get these people in like the 10s or 20s of LDL or ApoB, you end up with super low LDL and you could reverse some heart disease. We don't know yet, it's kind of new. But you can check your ApoB and that'll give you like kind of your real particle count. So someone with an LDL of -10 is not really -10. If you check their ApoB, it's probably like 23, 24, something like that. So just be careful with that. I think, let me get into how much time do we have? I haven't even started. We're just on the intro slide. We're good? Okay, let me see. So you can connect with me in lots of different ways. I get like almost 10 million views. I get like 10 million views a month now. Follow me on any of these things. You can watch my little videos. These are lipid textbooks that are out. I actually wrote a lipid textbook too. It's called Cholesterol Truths. The co-author is Dr. Thomas Dayspring. He's like the world's greatest lipid educator. The president of the European Atherosclerosis Society is on here. Tons of other cardiologists. I'll pass this around. You guys can check it out. It's 516 full color pages. So check it out. See if you like it. I have no disclosures other than the book. That's why I did that. Yeah, these are the books. I wrote several books. I have an app called the Dr. Allo app. You can download and watch most of these lectures, including this one. I'll upload it for free. Objectives. I mean, these are the general objectives of today's talk. Doesn't seem like we're going to get past 1 or 2. This is normally like a 5-hour lecture. We like to practice preventative cardiology. The reason I like to talk about preventative cardiology is because if we get everybody's LDLs down for a long enough time horizon at an early enough age, you will never have heart disease. Those people with hypobeta lipoproteinemia that I talked about earlier, they have a genetic PCSK9 loss of function mutation. You know when you take Repatha, not you, well maybe you, but if you take Repatha or give it to your patients and their LDL goes down to, with Crestor, with Zetia, whatever, it goes down super low, some people are born with that. it's called a PCSK9 loss of function mutation. Their LDLs are like 5, 10, 15 for their entire lives. They will never have heart disease. So we would like to prevent cardiology rather than treat it later. Unfortunately, here at the hospital, it's like a tertiary care center, academic center. We see the craziest, nastiest heart disease you'll ever see. So I'm not going to get into this. There's cardiologists and there's lipidologists. You all can be lipidologists. Anybody who's internal medicine, anybody who's a doctor can go to the National Lipid Association and sign up to take their courses and classes, sign up for the board exam, and become a board certified lipidologist, which that book will help you tremendously, actually. So why lipids? This is like the master chart, all right? If you remember anything from this talk, this is the one chart you want to remember. Brian Ferentz and his group in 2017 wanted to see, can we prove that LDL causes atherosclerosis? Because you see a lot of people online, they're like, LDL doesn't cause heart disease. It's just here to put out the fire. We got to put out the fire, which is inflammation, which is not true. There are people born with no inflammation but super high cholesterol, like little kids with familial hypercholesterolemia. They're born with LDLs of 300. They have no inflammation. They're little kids. Like you can measure their CRP. It's like 0. Their SED rate is not that high. Their IL-6, IL-1, IL whatever, TNF-A, and all these like inflammatory markers. You can measure all of them. They have no inflammation whatsoever, yet they have insanely high, these are the familial hypercholesterolemia homozygous people. They have an LDL receptor mutation. They have insanely high LDLs, and they all have heart disease. So this chart wanted to look at how can we prove that LDL causes heart disease? Does it meet the criteria for causation? It's a brilliant article. You can look up Brian Ferentz. But if you notice this, do you guys know what Mendelian randomization is in studies? What is that? It's people who are born at birth with either insanely high cholesterol, like familial hypercholesterolemia, or hypo-beta lipoproteinemia, where they have like almost no LDL cholesterol, and everything in between. So you are randomized at birth. Some people, you get an LDL of 900, you get an LDL of 5, and everything in between. And this is what happens. As the LDL goes down, the risk of heart disease goes down to almost 0. Like I said, the people with hypo-beta lipoproteinemia have like no heart disease. It's below the 1% even. So those are randomized, Mendelian randomization. You're born with either super high or super low LDL. What about cohort studies? Do you guys know what a cohort study is? You kind of watch people. There's like all these cohorts. There's like the nurses' health initiative and the women's health initiative and the physicians this and the chimney workers, whatever. Like they have these huge cohorts and they follow them over decades. They're just observational. You can compare cohort to cohort, and you can compare, like, what if we look at all physicians that don't smoke, have a normal BMI, no hypertension, no whatever. We watch them over 40 years, and then we just stratify them on the ones that have the highest LDL versus the ones that had the lowest LDL. This is what happens. The people with the lowest LDLs, if you just watch them over time, had almost no heart disease. The higher the LDL, the more heart disease they had. Do you guys know what a randomized control trial is? This is the red ones. Do you guys know what these are? What's a randomized control trial? We lower your LDL, all right? We take a big group of people, 20,000 people, and we say, you're going to get this treatment, and you're going to get this treatment, or no treatment, placebo versus treatment, and it's double-blinded. It might not be double-blinded, but usually they are. But the treatment might just be exercise or diet, right? Diet, obviously. But the treatment might be you just cut out saturated fat. Or it might be you take statins, or it might be like down here with Fourier, which isn't even on here. Improve-It is on here. Prove-It, Ideal. I don't know if you guys have studied all like the lipid, historic cardiovascular studies. They didn't even add Fourier yet in Odyssey, which is Repatha and Praluent, which are the 2 PCSK9s. There's also inclisiran now. Do you guys know what inclisiran is? It's super cool. It's an injection that's every 6 months, which they're coming out with some that are going to be once in a lifetime. But it's an mRNA silencing. It's a gene editing, gene silencing, CRISPR technology. You guys should look into it if you don't know about it. It's super cool. But anyways, that doesn't even include those. But no matter how you lower cholesterol compared to placebo, you had less and less and less and less heart disease. And that includes even diet. Like if we tell you just cut out saturated fat and lower your LDL by 34 points. So in America, we measure it in milligrams per deciliter. most of the world uses millimoles per liter, and it's usually 1. They usually say like one millimole is about 38.6, 38.7 milligrams per deciliter. For every 1 millimole reduction in your cholesterol, let's say 38, like for you guys, let's say you're 138 and you drop it to 100, or you're 100 and you drop it to 60 something, 65, I don't know. You end up with a 26% reduction in cardiovascular outcomes. All endpoints, whether it's non-fatal MIs, heart attacks, strokes, death, mortality, whatever, you get a gigantic reduction in almost everything. So that's why I think this slide is super important, because this kind of summarizes everything you need to know about cholesterol. The reason this is important is because you have a lot of crazy people, including actual doctors. This is an actual physician at Cleveland Clinic, mind you. This is Dr. Mark Hyman, who's a functional whatever. He and this doctor who lost her license, chiropractors, family doctors, orthopedic surgeons, I don't know what he is, physician's assistants, I think he's a psychiatrist now, and Liver King. Yep. These are all online influencers with millions of followers that tell you high cholesterol is not a problem. So you're up against a bunch of idiots with super high follower counts. I mean, when this guy is giving America advice on cholesterol, we have a huge problem. And then you got the chiropractors. These guys are the best. They're like, and I apologize if some of your friends are chiropractors, but literally you come in and they like wiggle your toes until you need vitamin A or something. and this is just insane. And then the funniest part, almost all of them, they will tell you high cholesterol is not a problem, but buy my supplement to lower it. So if it's not a problem, why am I buying your supplement to lower it? Like, that makes zero sense, but it is what it is. And like I said, Cleveland Clinic, where this guy actually works, did a study called the SPORT trial, where they studied all the supplements that he actually sells to test them against placebo or Crestor 5. Crestor 5 lowered people's LDLs 35 to 55%, almost 60%. Placebo did almost nothing. All the supplements he sells didn't beat placebo, just so you know. Garlic, CoQ10, fish oil, cinnamon. Cinnamon actually raised inflammation. Oh, it's the inflammation. Cinnamon actually raised CRP. What else did they have in there? I don't know. All the nonsense that he sells, Cleveland Clinic tested. His own place where he works tested his nonsense, and it doesn't do anything. It doesn't beat placebo. Like if I tell you to eat air, like if I go like this, that beats better. That is better for you than taking cinnamon or CoQ10 or whatever he's selling. And lettuce is colored there, by the way. So this is atherosclerosis. It's important to put this up because the beginning stages, like we don't have to have atherosclerosis. This is normal. This is early. This does not have to happen when your LDL's. So what's like the LDL cutoff? Do you guys know? Like at what LDL level in milligrams or like nanomoles? I don't know how many guys do nanomoles or millimoles. What's like the milligram cutoff where you start building plaque that we found in most studies?
46.
Huh?
55.
About 55. Like if you look at the Jupiter trial, it was like 57. The PISA trial was also like around 55, 60. So we think that 60 milligrams or higher, 60 milligrams per deciliter or higher of LDL, most people are probably building plaque, which is about 1.2 in millimoles, maybe 1.4 at the most. So I don't know how everybody measures it differently. But this is how it progresses. You don't see calcium till here. Like how many guys are like, Doc, how many guys see patients like, Doc, my arteries are good, I had a calcium scan, and it was fine. So he's literally like right here. He's like, I had a calcium scan, and I'm fine. And he's not fine. He has like a 50% occlusion of his artery. He's like, oh, I did a calcium scan, I'm good. Calcium detects very late stage disease. By the time these are called crystallopathies in medicine. Necrosis of the lipid plaque is a crystallopathy. Calcium is part of the crystals, and calcifies. It can't get calcium out of there. Not that it matters all that much, but you could stop it. If a patient comes to you and says my calcium score is like 100, or the most I've ever seen is like 4,800, you could stop it, but it's a little bit late. But it's not too late. You shouldn't tell your patient, oh, it's too late, you're gonna die tomorrow. Like, no, that's crazy. We can stop it here maybe. Let's say it hasn't ruptured yet. Let's say like it's still, got a thin fibrous cap. They got like a thin fibrous cap. Hasn't ruptured yet, but we can get it maybe to regress back to this way. Like, they didn't get the calcium yet, or maybe there's some, but you can get it to regress and get a thick fibrous cap. If you can get the thick fibrous cap, then it won't rupture. So it's not super important to just, obsess over calcium. A lot of people are obsessed over calcium. They're like, doc, I'm not taking the medicine until I get a calcium scan. Like, okay, that's nonsense. Like, let's say we did a calcium scan when you're like here, and it's not, and it's negative, it's 0. And then you do it again 5, 10, 15 years later. Now it's here. It's just where you're like, okay, now I'm going to take the medicine. Have you guys ever told your patients they could keep smoking? Like if a patient comes to you and they're a smoker, you'd be like, oh, keep smoking. We did a CT scan, you don't have cancer. You should keep smoking. Does anybody do that? Why not? Unless he's 90 years old. So let's say he's not 90. Let's say he's like 50. 50-year-olds, 40-year-olds, 60-year-olds. They come to you and they're like, doc, I just got a CT scan. My CT scan shows that I don't have cancer. I'm just going to keep smoking, right? Would you tell them that's a good idea? That's a really dumb idea. Like really dumb. I don't even it's worse than dumb, but I can't say anything else. So it's really, really bad advice to tell your patient to keep smoking because the CT scan doesn't show nodules or cancer or calcium or whatever it is. So same thing with heart disease. We have ways to arrest heart disease over here. We don't need to go past normal. We have medications now. If this was like 20 years ago or 15 years ago and we didn't have Repatha, we didn't have PCSK9s, it's very hard to get people's LDLs that low. But now it's 2026 almost. Why is anybody's LDL realistically over 60? I know that's not what the guidelines say, about minus 41, and I'm planning on like just keeping it there. But either way, like you don't want to wait till the last minute or a very late stage. And don't get me wrong, if this is in the arterial wall and the lumen's still about 50 or 60% open, they might not even feel anything. They could run marathons, they could do whatever. This does not mean it's symptomatic. Sure, if they get like to this stage where they're like 15 or 20% left, like a 70, 80, 90% blockage, yeah, they're going to feel it. But if they're still, 40, 50, 60% blocked, they may or may not feel it. So you could do a stress test. If they pass and they got good flow and they didn't feel any symptoms, they're probably fine. But definitely you want to stop. Like you don't want it to keep going, right? How long do we have? So these are, we got time. Okay. So these are generally the tests you want. You want to get fasting lipids, mainly to get fasting triglycerides. Why? Anyone? Okay, you're allowed to say stuff if you're on cardiology. Mainly because like if you have hypertriglyceridemia and your triglycerides are over 500 or in the 2,000 to 3,000 range, that's a huge problem, right? You have to get that down immediately. There's lots of ways to do that. This isn't a triglyceride lecture, but we could talk about how to lower those later. But if it's over 500, 499 and up, or 500 and up, basically it's kind of a medical emergency. You've got to get them down. It can cause pancreatitis, which can lead to pancreatic cancer and all kinds of problems. You also want to get something called a lipoprotein A, which we haven't discussed yet, and this apolipoprotein B. That was that big like structural protein on the lipoprotein. So we get a particle count. So what are your goals? What should your LDL goal be? Like what is the guidelines now state? The European Atherosclerosis Society, you got the book somewhere? Yeah, the guy on the back of the book, Professor Causation, they finally agreed. I sent him this book and he helped me write parts of it like almost 2 years ago. The European Atherosclerosis Society finally agreed with my recommendations, mine and Dr. Lipid's recommendations. And I'll tell you what they are, but what do you guys think are the lipid guidelines now? 2018, they changed them, obviously. Some labs still report that LDL 130 is fine, or heaven forbid 160 even before that. So what is it? All comers, no risk factors. What should your LDL be? I'm hearing a lot of things. Somebody with a lot of confidence say one number. 100. Okay. So all of you should have an LDL of no higher than 100, right? What if you have one risk factor?
77.
Like, for example, being a male. How many of you are males? That's a risk factor, right? That's literally like 70, 60% of you guys. 60% of you have one risk factor. It's called being male, right? So if you're a male, that's a risk factor. So what should your LDL be? 70 or less. What if you're a male over 45? Now you got two risk factors. Any of you over 45?
45.
55? Women over 55, yes. But are there any males over 45 here? No, just me. Okay, so if you're a male and over 45, or a female over 55, or have diabetes, or hypertension, or overweight, or family history, or your diet is not optimal, whatever it is, then if you have one risk factor, you should be under 70, right? What if you had a cardiovascular event? You had a stent, you had a stroke, you had a TIA, you have peripheral artery disease, you had kidney, stenosis, whatever. Then what is your LDL goal? 55, right. So 55. Is there anything that needs to go lower than 55?
40.
Who needs to go to 40? Multiple infarcts or super high risk people. So the people that need to go below 40 are people who have multiple atherosclerotic events or have lipoprotein A elevation, or they're just like a nightmare. But usually it's multiple atherosclerotic events. Like they had a TIA, then they had a stroke, then they had stents, then they had open heart surgery, then they got to clean out their iliac arteries, then they had a kidney thing and they had to put a stent in there or whatever. So this is kind of how it works. Basically, everyone should be under 100. If you have any of these sort of risk factors that aren't super insane, under 70, 55 if you've already had coronary artery disease, and then under 40 if it's worse. And these pictures and all of this stuff is in the book, so you don't have to memorize it. And I put all these on YouTube and I put them in the app so you can grab it later. So these should be your LDL goals, right? And this is the 5th percentile. This is where almost nobody should have heart disease, but even if you're below the 20th percentile, you'll probably be fine. So ApoB is 70, LDL is also around 80-ish. LDL below 70, and now we recommend even lower to be for certain reasons, but this is about the 5th percentile. These are not the goals. These are just, if you looked at the MESA cohorts and large cohorts, only 5% of people have ApoB below 55, LDL under 70, non-HDL under 90, LDLP under 700, et cetera, et cetera. So this is not a goal. This is just what percentage of the people, if you looked at the general population, have these numbers. Most people have an LDL of 140, ApoB of 118, et cetera, LDL particle count of 1600. So this is not a goal of therapy. This is just a huge, the MESA cohort. This is what it turned out to be. Normally, we would like people below this so that nothing bad happens. Do you guys know what this is? So this is also in the book with a very detailed explanation. This is how cholesterol gets made and absorbed. All right, it's very, very detailed. Let's see, where can we start? So this is your liver. All right, this is a hepatocyte. This is a liver cell. Your liver can make VLDL. You can also put out HDLs, LDLs, IDLs, and the VLDLs can go down into IDLs and then LDLs. These are like your arteries in your heart where they drop off their cholesterol and it becomes a foam cell and eventually plugs up your arteries. Your liver can also send out cholesterol into your bile duct, into these things called micelles that form. And then the micelles, this is a micelle here in your intestines. This is a jejunocyte or an ileocyte. Here's both of them. This is an NPC transporter. This is where Zetia blocks. So cholesterol gets reabsorbed by these micelles back into your intestines, right? This is where Zetia works. It blocks the NPC1, which is, part of it is here, and there should be one down here, but either way. And then your intestines create chylomicrons, which are huge. These are 270 nanometers. These are huge. They get recycled, go back into circulation. They deliver cholesterol, like energy, to the muscles. If they need them, your muscles, your tissue needs energy, that's where it goes. And then the rest of it can be stored as fat if there's extra. Then it goes back to your liver to be degraded. And your liver can also put out these. And your liver can uptake HDL. Like this is an HDL molecule being taken back into your liver. Same with an LDL, same with whatever. LDLs can be involved in indirect reverse transport. So it's not only HDLs that bring cholesterol back to the liver. LDLs are part of that too. They're part of something called indirect reverse transport. Indirect reverse cholesterol transport. So this is kind of what we talked about earlier. This is a particle core of a lipoprotein. These are the triglycerides. These are the cholesterol esters. Cholesterol inside of it is an ester. All right. And these are the structural proteins. ApoB, which is the one we measure, is found on VLDLs, IDLs, LDLs, and chylomicrons. About 95% of it is LDL. ApoA1, capital A1 is not needed to be measured because each HDL particle can have 1 up to 5 of these. So it doesn't really give us an indication of how much HDL you have. And HDL is not really a factor. HDL is not cardioprotective. It's not helpful. There's almost no reason to measure HDL or even look at it. We used to think the more HDL you had, the better, and it's cardioprotective. And it's better to have more HDL to weigh out or outweigh your LDL, and it offsets it. Turns out none of that is actually true. And then this is like a lipid panel. These are total LDL particles. You have normal LDL particles and you have lipoprotein A. Lipoprotein A have this thing called a kringle on it. It's like a heavy weighted chain of molecules, I should say, like with more proteins on it. Lipoprotein A is found in about 30% of people, but we only check like 0.1% of all people. This makes your LDL 3 to 6 times more atherogenic. So we measure normal like LDL particles by checking ApoB, and these do have ApoBs on them. This brown little, mustache-looking thing is the ApoB particle. LDL lipoprotein A does have it, and it does pick it up. So when you check an ApoB, it also picks up LDL. This is your calculated LDL includes all the LDL that's inside. Your calculated cholesterol. LDL cholesterol is the cholesterol inside all of these particles. You can actually also measure a direct LDL, which is not usually necessary, but some labs default to it. Like their triglycerides are super high, they're over 400. The labs won't calculate an LDL, but they'll reflex to a direct LDL, which I don't know how useful that is. Just check an ApoB, which gives you a very accurate number. It's not dependent on triglycerides or how fasted you are. Like lipoprotein A and ApoB, it doesn't matter how fasted you are. This is again VLDLs, chylomicrons, which are huge. These are the ones that the intestines put out. All of these contain ApoBs, including lipoprotein A. So if you measure ApoB, there's 1 ApoB molecule per particle. And these are all the potentially atherogenic particles. 95% of ApoB is going to be LDL, honestly. So you'll get you're getting a very accurate count of total LDL particles when you check an ApoB. 95% of ApoB is usually this. These are very short-lived in circulation. Same with chylomicrons, so you mainly just get LDL, and this is a special type of LDL, the lipoprotein A. This is just another way of looking at it. You can measure triglycerides inside of VLDLs, IDLs, LDLs, HDLs. You can actually order these labs if you want. If you want a VLDL triglyceride, you can actually order that. I don't know why you would, but you could order triglycerides from each single one of these, which you don't really need to do. The ApoA1 is the HDL particles. The problem is, like I said, you could have 1 and up to 5 on each one, so it's kind of useless. Also, we don't really care how many HDL particles you have or don't have, so it doesn't really matter all that much. It's just another way of kind of looking at it. And then these are the different sizes. I don't know if this matters that much. The chylomicron is the largest, it's 270 nanometers. Everything else is tiny, like these. LDL particles usually are 18 to 25 nanometers in size. The gap junctions and the junctions between cells and your arterial wall and your endothelium, anything below 70 goes through. These are like 18 to 20. So they could passively diffuse even. They don't need to be like transcytosed or any of that. They could passively diffuse into your artery. So the only one that really can't is a chylomicron because it's gigantic. This is what a standard lipid panel looks like. You're going to get like your basic lipid panel. Maybe I'll skip ahead a little bit. So this is a good point. So if you have these are 3 patients with the same number of particles, right? These are 3 patients with the same number of LDL particles. So you have 9 particles here, 9 particles here, 9 particles here, right? These LDL particles have the most amount of cholesterol in them. They're huge. These ones have like a medium amount, and these ones have a very tiny amount of cholesterol in them. And they're all just based on size. So measuring just LDLP or ApoB doesn't necessarily always correlate with like total cholesterol inside these particles. So sometimes you should get a fasting lipid panel, obviously, because that's what we've been doing for 100 years. But getting an ApoB will tell you a little bit more about how many total particles you have, because if you just check the total number of cholesterol and they're very large, it's going to look like a lot. If they were really tiny, it's going to look like a little bit. Like LDL cholesterol here is like it's going to look like a 20, whereas here it could be 120. But it's the total number of particles that matters more than the actual cholesterol. We'll skip this one. There's a lot of these. When do you guys have to stop?
We have next lecture actually, but you can take over like.
Okay, so I'll keep going. This is kind of another depiction of direct reverse cholesterol transport and indirect cholesterol transport. These are all the different cells, steroidogenic tissue. These would be like your ovaries and testicles, your enterocytes in your intestines, how the bile, they go back into the bile, they get reabsorbed. It's just another way of all like the different pathways. Here's the indirect reverse cholesterol transport, the LDL particles, the HDL particles, let's say they collect cholesterol from your foam cells in your heart. Let's say it's an artery in your heart. They collect some of the cholesterol out of there. They give some of it to LDL, and LDL through indirect reverse transport can bring it back to the liver, or HDL directly can bring it back to the liver. So this shows you there's multiple different pathways. So a lot of people say HDL is the good cholesterol and LDL is the bad cholesterol. The cholesterol that's in it is neither good nor bad. And you can't really call an LDL lipoprotein good or bad because part of its life cycle it's helping. Like a huge part of its life cycle, it's helping HDL bring cholesterol back to the liver so it can be eliminated. So not always is LDL bad. I mean, generally it is, don't get me wrong. Like we don't want people to have high LDL because it might be helping transport. No, usually it's not. But it's a misnomer to a certain extent because in some cases it may be helping eliminate cholesterol. It's just another sort of diagram showing that. Okay, so this is like what happens inside of an artery, right? This is the blood flow going this way. Here you have the LDL particles. It kind of starts on this end. You have LDL particles. They get inside the arterial wall. This is the endothelium. There's junctions between the cells. These are endothelial cells. There's junctions and spaces between the cells. They get in. They get these reactive oxygen species, and they kind of like get oxidized and inflamed, and they start binding together, and then they dump the cholesterol out of them, and you form like these foam cells where they start to crystallize. All the cholesterol goes in there. The monocytes come in to try to attack this, right? Your immune system sends a special kind of T cell called a monocyte to come in and start attacking these to help clean it up. But then it gets also stuck in there, and everything necroses and dies, and it gets stuck in there. You start putting matrix proteins to try to cover it up with a fibrous cap. Sometimes a fibrous cap can rupture. Now you have a thrombus. If you want it to heal and close, you want like a thick fibrous cap. But this is just kind of like the process of how it happens inside an artery. And then you have people online telling you that the hazard ratios for heart disease are mainly type 2 diabetes and insulin resistance and all this stuff. Or they want to say small LDL is the bad boy, but not big LDLs. I told you, they're all like 18 to 20 nanometers. The difference in size is like, you can't even detect it. But they want to make it sound like everything else matters, but not LDL, not cholesterol matters. So you got to ignore these people. So what are the 9, let's say you've never had a heart attack or stroke. The Inner Heart study looked at the 9 factors that contribute the most to the first heart attack, right? Number 1 was lipids. 49% of the modifiable risk that's attributable to giving you your first heart attack was lipids. What's number 2? Smoking, psychosocial. Psychosocial is like where you live, how much food you have, how much access you have to healthcare, those kind of things. Abdominal obesity, hypertension, fruits and vegetables. How can fruits and vegetables contribute to your first heart attack? Not eating enough. Same thing with exercise, not enough. Diabetes, and then alcohol. So those people on that other page are like, it's the diabetes, it's the insulin resistance. Diabetes was like the last one. All right, so the number one risk factor that contributes the most to having your very first heart attack, and it's the most modifiable, obviously, is lipids. Well, these are all the modifiable ones. Obviously, you can't change your age or your genetics or whatever. Again, So they looked at lesions, and these are all like in the book too. They looked at lesions and how much can you regress them by. So if you have a lesion that's blocking 5% of your artery, in the first 20 to 30 weeks, let's say it goes up, and then you get on cholesterol treatment, the early lesion can regress back down. So a fresh lesion, it's only 20 to 30 weeks old, and may regress back down to almost nothing. If you continue on 40 weeks, now the lesion's a little more mature. If you get on lipid-lowering therapy and get your LDL low enough, you could get it down into the 5% range from, let's say, 13 or whatever that is. You get back down into a 13, into the 5%, 4% range maybe, but it's not going to go all the way back down to 0. The more mature and the longer they're there, the harder it is to reverse. Now you go further, 50 weeks or about a year, a lesion that's advanced, it's been there for about 52 weeks, let's say about a year. You get on lipid-lowering therapy, this is like a 15% blockage almost. It drops down to about a 6 or 7%, and it's not going to go any lower than that. The control, I don't know what the control is, but either way, like this demonstrates, and this is obviously before Repatha and Praluent, where we could really crash your LDLs, but now this is based on the normal therapies that we've had over time. This is kind of what happens. So people ask me a lot, can we reverse atherosclerosis? Kind of. Fresh plaque, like 20, maybe 30 weeks old, you can regress it quite a bit. As it's a year or more, it becomes harder and harder to reverse it all the way. You can get it down a little, but not a lot. This is just what a stent looks like. Have any of you guys been to the cath lab with us? Okay, so you put in a balloon, there's this piece of metal on it. This is the plaque, obviously. You go in, you blow up the balloon, it pushes the plaque out of the way, and then your body re-epithelializes this. It recoats it and it becomes artery, it becomes part of your arteries. Do not check calcium scores on people who have metal inside them. It's going to be very high. You can't do calcium on somebody who already has stents. I mean, you can, but it's useless because you have metal, and that's like calcium. So, this was something called the PISA trial. They looked at young people who really don't have very many risk factors. They found that LDL in the primary prevention, the lower the better, obviously, but they looked at, this was called they wanted to find atherosclerosis before it was obvious. Like it was, using very fancy imaging, like PET, MR, IVUS of like your femoral arteries and carotids. They looked at 6 different vascular beds. They found that 45% of young people with no known atherosclerosis had atherosclerosis. 45% if your LDL was 110. If your LDL was 130, it was 58%. If your LDL was 150, it was 64%. So 64% of people with an LDL of 150 that are only about 40 years old, the median age is about 40 years old, had atherosclerosis. And these are, and it was subclinical. They were using very fancy imaging that we don't use. It was research-based. They found that, in multiple vascular beds, this is what they had. This is my patient that had the LDL of -10, which, don't worry, it's not really that. It's probably like 15 or 20 if you check an ApoB. So how low is too low? People say, well, I don't want my cholesterol to go that low. Like, really bad stuff will happen. Turns out that's not true. The 4-year trial, which was the Repatha trial, sorry, I'm running out of breath here. I need some water. The 4-year trial called the OLE, there was an open label extension, right? The open label extension of the 4-year trial, which was Repatha, some people had an LDL of 0.2. Do you know what 0.2 is in milligrams per deciliter? So it's 3.8 times 2, basically. Like 7.5, 7.6, 7.7, something like that. So some people got down to an LDL of basically 7. They found nothing bad happens, and there was no safety concerns, and they found that they actually did better than people who wasn't that low. So some people are sometimes afraid of like, what if we go too low? What happens if like they get a -10 or -7? Turns out only good stuff happens when you go that low. And again, this was that same study by Brad Ferentz that showed that LDL is causal of atherosclerosis. It causes atherosclerosis. We're at 3 o'clock, right? Let me find some interesting. So you guys know primary prevention and secondary prevention. The Jupiter trial was rosuvastatin. It was a primary prevention trial. It had the most potent lipid lowering. This should actually be 57. This was the first time we could get people that low. Even atorvastatin 80, which is the second most potent, couldn't get people that low. But in the Jupiter trial, we got people into the 50s and they had like almost no events. But you notice the primary prevention is not as sharp as secondary prevention. Obviously, we know in secondary prevention, you can significantly reduce future events, and we're starting to see data now that you can reduce events in people who've never had heart disease. This is just another way of looking at this. Yeah, here's the Jupiter trial. This was 20 milligrams of rosuvastatin, like 57 was the number. And these are all the genetic mutations that you can have, and you'll notice this is an absolute change in LDL based on genetic problems. Familial hypercholesterolemia is the LDL receptor. This is a PCSK9 loss of function mutation, which we give you now with an injection. Some people had a negative change in relative risk, obviously, of heart disease. So some people had a 100% reduction in heart disease if they had this mutation. I could go on for 5 more hours. This is really long, but you'll find just the good slides. So there's a lot of articles on particle size, and it really doesn't matter. Total number of particles, though, absolutely matters. That's why ApoB or LDLP matters. Maybe we'll stop here. Do you guys have questions on anything? Oh, and so this was a good study. They looked at saturated fat. Below 6% of total calories, there's like total energy. Below 6% of total calories, the mortality and relative risk was pretty low. There was a sharp inflection point right around the 8% range, and then it kind of flattened out again. All-cause mortality, CV mortality, myocardial infarction, stroke, whatever, it all kind of flattened out. So there's a lot of people that'll do a study. They'll look at reducing saturated fat from like 26% of total calories to 12% of total calories. They'll say, well, not a lot changed. Well, you're in the flat part of the curve. Once you drop it down to 6%, below 8, below 7, below 6%, you see a huge reduction, almost no cardiovascular events. And then Finland, I'll just end with this. Finland in the 1960s had the highest level of cardiovascular death. They had 700 deaths per 100,000 people. And it was because they ate a lot of saturated fat. So they sent a bunch of researchers and like public health officials up to North Karelia. It was part of Finland, way at the top. And they told them stop eating saturated fat because it's killing you. Over the next, from 1969 through 2011, and it's still ongoing, by the way. You can look up the Finland study. 2018 is the latest data. They had an 84% reduction in cardiovascular mortality. They went from like 700 deaths per 100,000 to less than 100 per 100,000, which is incredible, just by cutting saturated fat. Like stop eating butter, bacon, lard, tons of egg yolks, whatever. Just that in and of itself over decades reduced their mortality. Any questions? All right, well, let me know if you have any questions. Maybe we'll continue next time.
Thank you.